Good morning, class. So today we're going to be going over to Chapter 9, Patient Assessment. Assessment applies scene information and patient assessment findings, scene size-up, primary and secondary assessment, patient history, and reassessment to guide emergency management. Scene size-up, scene safety. So the first thing, the most important thing on every call is your safety and the safety of your partner. Scene management, impact of the environment on patient care, addressing hazards, violence. So when you get a call, you're always looking to see where your call is at, seeing if there's any hazards. Say if you're going on a roadway, on a highway, you have a vehicle accident. You want to make sure that you park your ambulance in a safe area. Park it in front of the fire truck, because the fire truck should be blocking you. That way you can access your patient and you still stay safe on scene, as well as throwing on your safety vest. So need for additional resources or specialized resources. So like I was saying, if you have a vehicle accident, you're going to ask for fire. You're going to ask for a truck company if you need extrication or anything like that, or if you need PD. Standard precautions on every call. You're going to be having gloves at a bare minimum, safety goggles, also mask possibly, and a gown. Say if you have a pregnancy, or if you know somebody who has a cough, they're sick right now, or even TB, you're going to wear an N95 mask. Multiple patient situations. So if you know you have multiple patients, before you get out of the rig, you're going to ask dispatch for another unit. Primary assessment for all patient situations. Level of consciousness. As you're walking up, you're assessing the patient, even before you have a chance to talk to them. You're going to see if they're conscious or not. ABCs, airway, breathing, circulation. The most important part, because you can't do anything else if the patient doesn't have an airway, if they're not breathing, they have no circulation. You're going to identify any life threats, any major bleeding, anything else that you may see. Assessment of vital functions. Initial general impression. Are they sitting up? Are they face down on the ground? Are they laying in bed? So beginning interventions needed to preserve life. Are you going to give them oxygen? Are you going to C-spine them? Integration of treatment procedures needed to preserve life. So are you going to throw an airway adjunct in them? Are you going to start bagging them? Are you going to give them oxygen? Are you going to start CPR? Anything like that. History taken. Determining the chief complaint. Why did you get called? You're going to ask the patient. You're going to introduce yourself. My name is Brian. I'm an EMT. What seems to be the problem today? And they're going to tell you shortness of breath, chest pain, abdominal pain, anything like that. Mechanism, injury, nature of illness. So it's either going to be a trauma or a medical, or it could possibly be both. Associated signs and symptoms. What is the patient telling you what's wrong with them? What do you see that might be wrong with them? Okay. Investigation of the chief complaint. You're going to keep asking them questions regarding the nature of the incident. Okay, you're going to ask OPQRST for chest pain, or you're going to ask PACE, the acronym for any shortness of breath, any respiratory difficulty. Past medical history, that gives you a good indication of possibly what's going on with the patient. If they have a chronic condition, hypertension, history of irregular heartbeat, any heart attacks in the past, any strokes in the past, that could give you kind of a pathway to what you're asking. Pertinent negatives. Some of the questions, so if they're having chest pain, are they having any shortness of breath? Are they having any abdominal pain? If they deny all those would be pertinent negatives. Secondary assessment. So you're going to go ahead and perform a rapid full body scan after you're done with your primary assessment. Focus assessment of pain. The patient slowly complaining of chest pain, you're probably just going to narrow in on the chest pain. Assessment of vital signs. So you're going to go ahead and take a minimum at a blood pressure, respiratory rate, and pulse. Techniques of physical examination. Respiratory system. Presence of breath sounds. So you're going to get your stethoscope out. You're going to listen to lung sounds, both upper and lower, and even on the sides or the flanks. Techniques of physical examination. Cardiovascular system, neurological system, musculoskeletal system, all anatomic regions. Okay. Monitoring devices. Obtaining and using information from patient monitoring devices included, but not limited to, pulse oximetry, non-invasive blood pressure. So for people with some chronic conditions like COPD or CHF, they might be monitoring their own oxygen level. They might be on oxygen at home. They're going to know how much oxygen they normally get on room air, or on 2 liters, or on 4 liters. And some people take their blood pressure. They've been told by their doctor that they need to take their blood pressure. They have their own blood pressure machine at home, and they take it constantly. They take it once in the morning and once at night because they have high blood pressure. So reassessment, how and when to reassess patients. How and when to perform a reassessment for all patients. So for trauma patients, you're going to reassess at a minimum every 5 minutes. For an unstable patient, for any stable patient, you're going to reassess at every 15 minutes. You're always going to get 2 sets of vital signs no matter what. Whatever call it is, you're going to get 2 vital signs. If you're 3 minutes away from the hospital, you're going to have 2 sets of vital signs no matter what. And you're always reassessing no matter what. Patient assessment is very important. EMTs must master the patient assessment process. Patient assessment is used to some degree in every patient encounter. 5 main parts. Scene size up. So before you even get out of the ambulance, you're doing penman like we went over. You're doing PPE. You're going to evaluate the scene for safety, number of patients, mechanism of injury, additional resources, need for C-spine. Primary assessment. General impression when you're walking up to the patient. You're always looking at the patient. You're always seeing what's wrong, what position they might be in, to kind of give you some clues before you even talk to the patient. You're going to check ABCs. You're going to do any life-threatening injuries that you might have to take care of rapidly. So history taken. Allergies, meds, and history. You always take that from every patient. Okay? Secondary assessment. You're going to go on and ask them any questions regarding their main chief complaint. You're going to get vital signs. You're going to do an assessment, a full body assessment. Right? And then you're going to reassess. You're always reassessing no matter what, on every call. Rarely does one sign or symptom show you the patient's status or underlying problem. Symptom, subjective condition that the patient feels and tells you about. Okay, so this would be, I'm having chest pain, I'm having abdominal pain. Something that the patient is telling you. A sign, objective condition you can observe about the patient. Does the patient look pale? Does the patient look sweaty? A diaphoretic? Is the patient bleeding? Does the patient have lacerations? Anything that you can see is going to be an objective condition, and that's going to be a sign. A symptom is what the patient tells you. So scene size up, your evaluation of the conditions in which you will be operating. Maintain situational awareness. Scene size up combines an understanding of the situation and conditions prior to responding. So dispatcher's basic information. On most calls, you're going to get some basic information. 31-year-old female complaining of abdominal pain. Pregnant, 30 weeks. That might be your basic information. That's all you're going to get. Sometimes you get patients asking for an ambulance. So you can't always rely on dispatch to get you all that information. And then observation of the scene. When you come up, you're always observing the scene to make sure that it's safe before you go in, or if you need to ask for PD, or if you need to ask for additional resources. So ensure scene safety. Issues can range from minor difficulties to major dangers. Do not enter the scene until it is safe for you and your team. Typically, the way you enter an area is the way you leave it. Wear a high visibility safety vest on roadways. So for pretty much every company I worked for, anytime you're out in the street or you're on the highway, it's mandatory that you're wearing a high visibility safety vest, or one of those yellow reflective vests. So consider difficult terrain. Is a patient down the side of a ditch? Is he up the mountain? Consider traffic safety issues. Are you on the highway? Are people going 80 miles an hour? Is it a one-way street? Consider environmental conditions. Is it windy? Is it raining? Is there lightning out? Anything like that. If appropriate, help protect bystanders from becoming patients. So if you come up on an accident, people are going to be outside, and if they are part of the accident, if they're not injured, or if they're just bystanders, we're going to make sure everyone moves off to the side of the road so no one else becomes a patient. So hazards range from extreme weather conditions to the threat of physical violence. An emergency scene is a dynamically changing environment. If the scene is unsafe, make it safe if possible. If this is not possible, move to a safe location. You're in an uncontrolled environment. You guys have to understand that. Things can go wrong real quick. So it's important to constantly monitor the scene for safety. Okay. Determine mechanism of injury, nature of illness. Calls for assistance can be categorized as medical conditions, traumatic injuries, or both. A medical problem could lead to a traumatic injury. Say a patient has a seizure while they're driving and they crash into the center divider. So now you also have a medical condition because the patient had a seizure and the patient crashed his car. So it's going to be a traumatic injury. So mechanism of injury, type or amount of force, how long it was applied, where it was applied to the body. So fragile and easily injured areas include the brain, spinal cord, and eyes. Blunt trauma. The force occurs over a broad area. Skin is usually not broken. Tissues and organs below the area of impact may be damaged. Penetrating trauma. The force of the injury occurs at a small point of contact between the skin and the object. Open wound with high potential for infection. So anything that breaks the skin, anything that causes bleeding is going to be a penetrating trauma. For medical patients, determine the nature of illness. Similarities between MOI and NOI. Both require you to search for clues. So you basically act like a detective. You're asking questions on every call, and you're trying to get as much information as you can from the patient and from any bystanders. You know, you're talking with the patient, family, or bystanders. Use your senses to check for clues. Because you have a limited amount of time with patients on scene and en route to the hospital. You want to get as much information as you can. Be aware of scenes with more than one patient with similar signs or symptoms. Example, carbon monoxide poisoning. Could indicate an unsafe scene for the EMT as well. Sorry about that, class. So considering the MOI or NOI can be of value in preparing to care for the patient. You may be tempted to categorize the patient immediately as either trauma or medical. Fundamentals of good patient assessment are the same. Don't get tunnel vision. Just because it looks like it might be just a medical or looks like it might be a trauma. You're always asking questions. You're always trying to figure out what's going on and what the patient's chief complaint is. So take standard precautions. Wear personal protective equipment, PPE, should be adapted to the pre-hospital task at hand. So he's got his PPE on, he's got his gloves, and he's also got a face shield. Standard precautions have been recommended for use in dealing with objects, blood, body fluids, other potential exposure, risk of communicable disease. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. At a minimum, gloves must be in place. Consider glasses and a mask. There are some people who wear glasses on every call, and that's perfectly okay. But gloves are mandatory for every call. During scene size-up, accurately identify the total number of patients. Critical in determining the need for additional resources. When there are multiple patients, use incident command system, identify the number of patients, and then begin triage. So it's important to get on scene and determine how many patients you have, how many patients are critical, and how many patients you can handle. Always ask for more resources than needed, because you could always cancel them, especially if you're way out there and it's going to take some time for resources to show up. Go ahead and call as much resources as you need, even more, because you could always cancel. So triage is the process of sorting patients based on the severity of each patient's condition. So if there's a bus crash with 30 people involved, you want to figure out who is going to be critical, who's going to be semi-critical, and who's walking and talking but injured. Okay, lower level. So there's different types. We have, I believe it's green, yellow, red, and black. So black would be dead. Red is critical, so severe patient. Yellow is injured, but they could be delayed. And green is injured, but stable. So some situations may require more ambulances, specialized resources. So these are hazmat suits right here. So, and he's also got some type of gas monitor. So if there's a hazmat incident, you guys aren't going in. You guys are waiting outside until they figure out what's going on, how to stop the leak or whatever is going on. Specialized resources include advanced life support, ALS. So that would be anybody like a paramedic who could push drugs, do IVs, advanced airways, anything like that. Air medical support, fire departments who may handle high-angle rescue, hazardous materials, or water rescue. Law enforcement. To determine if you require additional resources, ask yourself, does it seem pose a threat to me, my patient, or others? How many patients are there? Do we have the resources to respond to their conditions? So if you get on scene and someone's being violent, or you think a scene's bystanders, family, patients is going to escalate in a possible violent situation, you should call for PD. How many patients are there? Is there more than you could handle on scene? Is there more than you could transport? If there are, we're going to ask for more ambulances, more resources. And do we have the resources to respond to their conditions? Is the vehicle stuck in a tree? Is the vehicle off to the side of the road? We're probably going to need fire to help get them down. High angle rescue. So primary assessment begins when you reach your patient. The goal is to identify and initiate treatment of immediate or potential life threats. Physically examine the patient and assess LOC, level of consciousness, ABCs, airway, breathing, circulation. So when you go on scene, you're going to go up to the patient, see how he's presenting. Is he sitting in a chair? Is he laying on the floor? Is he laying in bed? Is he face down on the floor? So when you walk up, hi, my name's Brian, I'm an EMT. What seems to be the problem today? If they're sitting in a chair and they're looking at you, they're what they call is tracking you. When you walk in, their eyes are following you. That means they're tracking you. So it looks like he's level of consciousness. And so he comes in, oh, I'm having some chest pain. Okay, so right then you've accomplished two things. He's got an airway. He's talking to you. Breathing. Does he look like he's having trouble breathing? Okay, so if he's talking to you, he's most likely breathing. And you go ahead and go to his side and check his radial pulse while you're talking to him. So you can knock all three of those things out in the span of 10 seconds. So form a general impression. Form to determine the priority of care. First part of primary assessment. Make a note of the person's age, sex, and race. Level of distress. Overall appearance. So how does the patient look to you? Does he look like he's having trouble breathing? Does he look like he's having crushing chest pain? Is he able to answer your questions? Is he alert? Is he unconscious? Anything like that. So note the patient's position. Avoid standing over the patient. Address the patient by name. Introduce yourself. Ask about the chief complaint. Address life threats immediately. Determine if the patient's condition is stable. Stable but potentially unstable. Unstable. So the level of consciousness, LOC, can tell you a great deal about the patient's neurologic and physiologic status. Categories: unconscious, conscious with an altered LOC, conscious with an unaltered LOC. So patients can be conscious, but they could also be altered. Maybe they're having a stroke. Maybe they're hypoglycemic, but they are still conscious. They're still alert. Assessment of an unconscious patient focuses on airway, breathing, and circulation. Sustained unconsciousness should warn you of a critical respiratory, circulatory, or central nervous system problem. So say if you get called to a seizure, most likely patient's going to be what they call postictal. It's the stage after a person has a seizure. They're probably going to be unconscious, but they're most likely going to have an airway. They're going to be breathing. So we want to make sure their airway is open. We could do either a jaw thrust or a head tilt chin lift, depending on if you think it's a medical or a trauma. And you want to make sure that they're breathing. Most of the time when I come on scene, I'm going to give patients oxygen because of the seizure that they had. Conscious with an altered LOC may be due to inadequate perfusion. Perfusion is the circulation of blood within an organ or tissue. So, like I said before, patients with COPD or CHF may have low pulse oximetry. So a good pulse oximetry is going to be 94% to 100%. But due to their condition, 90% might be good for them, might be okay for them. So if you have a person at 80%, they're probably not going to be perfusing very well. And so that might be, they're not getting enough oxygen in their brain. So they're going to have an altered LOC. Could also be caused by medications, drugs, alcohol, or poisoning. To assess for responsiveness, use a mnemonic AVPU. So awake and alert, responsive to verbal stimuli. So you could either give them a shoulder pinch or a sternal rub. For responsive to pain, it's going to be a sternal rub or a shoulder pinch, and then unresponsive. So these are also different ways to test responsiveness to painful stimuli. You can pinch your earlobe. You can press down on bone above the eye. Pinch neck muscles. So, orientation test mental status. Evaluates a patient's ability to remember person, place, time, and event. So this is going to tell you if they're alert and oriented times 4. So if you get on scene and you evaluate a patient and they say they don't want to go to the hospital, you have to ask them these 4 questions before you could legally leave them and legally have them sign an AMA. So, evaluates long-term memory, intermediate-term memory, and short-term memory. Alter mental status. Any deviation from alert and oriented to person, place, time, and event. Any deviation from the patient's normal baseline. So if they can't answer those 4 questions, they are considered altered, and you cannot leave them legally. Identify and treat life threats. Conditions that cause sudden death, airway obstruction, respiratory failure, respiratory arrest, shock, severe bleeding, primary cardiac arrest. In most cases, begin with the airway, followed by breathing and circulation. If the patient doesn't have an airway, you can't do breathing and circulation. You can't go on to the next step. In some cases, it may be appropriate to address life threats to circulation first. CAB. Assess the airway. Moving through the primary assessment, stay alert for signs of airway obstruction. Ensure the airway remains open, patent, and adequate. Responsive patients. Patients who are talking or crying have an open airway. So if you get on scene and you get a call for a pediatric, if pediatric is crying and screaming, that is a very good sign for first responders. I always want a baby who's crying because that means that they have an airway. If they're not crying or screaming, something might be going on. So watch and listen to how patients speak. If you're concerned that patient might have a stroke, they might have some slurred speech. So listen to them carefully how they speak and ask bystanders or ask family members, is that normally how they speak? When's the last time they were seen normal? If you identify an airway problem, stop the assessment and work to clear the patient's airway. Unresponsive patients, immediately assess the airway. Use a jaw thrust technique when necessary. So if you have a trauma patient, you're using the jaw thrust. Use the head tilt chin lift technique when necessary. So you can use this on every patient that's not a trauma patient. Relaxation of the tongue muscles is a cause of airway obstruction. So the tongue could fall back and cause an airway obstruction. Signs of obstruction in an unconscious patient. Obvious trauma, blood or obstruction. Noisy breathing, snoring, bubbling, gurgling, crowing, abnormal sounds. Extremely shallow or absent breathing. Assess breathing. Make sure the patient's airway is open. Make sure the patient's breathing is present and adequate. Ask yourself, is the patient breathing? Just because they have an open airway, the patient could be in respiratory failure or respiratory arrest. And is the patient breathing adequately? A normal adult should breathe about 12 to 20 times a minute. Anything below that or past that is a concern. And that's a concern, you might have to fix it. Is the patient hypoxic? Do they need oxygen? Are they perfusing? Does their skin look cyanotic? Consider providing positive pressure ventilations with an airway adjunct when respirations exceed 28 breaths a minute. Respirations are fewer than 8 breaths a minute. So you're going to put an OPA in somebody if you believe they need assisted breathing. The goal for oxygenation for most patients is an oxygen saturation approximately 94% to 99%. So even if a patient's breathing is getting good oxygen within this range, there's a possibility they still might need help breathing. So always treat your patient. Don't treat the monitor. Observe how much effort is required for the patient to breathe. The retractions, use of accessory muscles, nasal flaring, 2 to 3 word dyspnea. So basically, if you ask a patient a question and they try and explain it to you, are they speaking in 2 to 3 word sentences because they can't catch their breath or they're short of breath? So tripod position, when you come in and you get a call for difficulty breathing, are they sitting down, hunched over with their hands on their knees, trying to breathe? Sniffing position, labored breathing. Respiratory distress, increased work of breathing, increased effort and rate. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meeting the oxygen demands of the body. The ultimate result of respiratory failure if it is not corrected. Okay, assess circulation, assess mental status. Is the patient alert and oriented? Is the patient conscious? Okay, pulse, skin condition. Are they pale, cool, diaphoretic? Are they cyanotic? Do they look like they have good skin color? Assess pulse. The pulse is the pressure wave that occurs as each heartbeat causes a surge in the blood circulating through the arteries. Palpate the pulse. So we've gone over this, where your pulse is going to be. In your wrist, the radial, and the humerus, and the brachial, the carotid, the femoral, the popliteal, the pedal, and the one behind your ankle. If you cannot palpate a pulse in an unresponsive patient, begin CPR. Skin condition. Evaluate the patient's skin color, temperature, moisture, and capillary refill. A normally functioning circulatory system perfuses the skin with oxygenated blood. Skin color, determined by the blood circulating through vessels and the amount and type of pigment present in the skin. Poor circulation will cause the skin to appear pale, white, ashen, or gray. So, when blood is not properly saturated with oxygen, it appears bluish. Changes in skin color may result from chronic illness. Okay, so when babies are born, we're going to do the APGAR scale. Okay, appearance, pulse, grimace, activity, and reflex. And it's to be scored on a 0 to 10 scale. So skin temperature. Normal skin will be warm to the touch, 98.6 Fahrenheit. Abnormal skin temperatures are hot, cool, cold, and clammy. So if patient's really sick, what we call as sepsis, their infection has gotten into their blood, so they could either be really warm or they can be really cold, or the environment. They might be having a heat stroke, or Or they might be suffering from hypothermia. What's the weather like outside? Remember? Situational awareness. Skin moisture. Dry skin is normal. Skin that is wet, moist, or excessively dry and hot suggests a problem. Capillary refill. Evaluated to assess the ability of the circulatory system to restore blood to the capillary system. Press on the patient's fingernail. So we just did this last week. You remember? We want to see if the patient's got good capillary refill. Remove the pressure. The nail bed should restore it to its normal pink color. Know how long it should restore. So for adults, it's going to be within 2 seconds. So you want to press down on the skin bed. Excuse me. So you see how it's pink, and then as soon as you press down, you kind of see it right here. It's going to be a little white, and then as soon as you release it, it should return to pink within 2 seconds for an adult. Assess and control external bleeding in trauma patients. Should occur before addressing airway or breathing concerns. Bleeding from a large vein is characterized by a steady flow of blood. Bleeding from an artery is characterized by spurting flow of blood. So if a patient has some type of external bleeding that they could bleed out really quickly, you're going to try and stop that first before you assess the airway. Controlling external bleeding can be simple. Apply direct pressure. Apply tourniquet if direct pressure is not quickly successful. Obvious arterial hemorrhage of an extremity. So if you're putting pressure and you're holding that extremity down or wherever it's bleeding and it's not working, apply a tourniquet as fast as you can. Perform a rapid scan. Scan the body to identify injuries that must be managed or protected before the patient is transported. It takes 60 to 90 seconds to perform, not a systematic or focused physical examination. So like I said on every call, when you're walking up on scene, you're looking at everything, and you're also looking at the patient. Are you seeing any bleeding coming from anywhere? If you're having an unconscious patient is probably not going to tell you much, especially if no one else is around. You have to figure out what's going on by yourself. You have to scan the body, see if there's any broken bones, any bleeding going on. Determine priority of patient care and transport. Primary assessment assessed in determining transport priority. High priority patients include those with any of the following conditions: unresponsive, poor general impression, difficulty breathing, uncontrolled bleeding, responsive but unable to follow commands, severe chest pain, pale skin or other signs of poor perfusion, complicated childbirth, severe pain in any area of the body. The golden hour, the golden period, is the time from injury to definitive care. Treatment of shock and traumatic injuries should occur. Aim to assess, stabilize, package, and begin transport to the appropriate facility within 10 minutes after arrival on scene. So platinum 10. So even in our protocols, they ask us to get on scene and get off. If we have a trauma patient, that's critical, because we got to be within the golden hour. We have to get them to the hospital, get them seen by a doctor. So this kind of gives you a breakdown of what it looks like. So discovery of incident activation of EMS is going to maybe take 20 minutes depending on how fast the call comes in and how quick or how close the nearest unit is to that call. And then 10 minutes on scene, the platinum 10 minutes. You're going to do your assessment, intervention if needed, and package the patient. Basically packaging the patient is either you're getting them on a gurney and you're taking off, or you're getting them on a C-spine on a backboard, and you're going to get them to the hospital as fast as you can. And then 30 minutes. So EMS transport and initial hospital stabilization. So transport decisions should be made at this point based on patient's condition, availability of advanced care, distance of transport, and local protocols. History taking provides detail about the chief complaint and the patient's signs and symptoms. Includes demographic information, date of the incident, patient's age, gender, race, past medical history, and current health status. Investigate the chief complaint. Make introductions, make the patient feel comfortable, and obtain permission to treat. Ask a few simple and direct questions. Refer to the patient as Mr., Mrs., or Mrs. or Mrs. using the patient's last name. Ask open-ended questions. This gives patients an ability to further answer the question in their own terms. If the patient is unresponsive, patient information includes about the incident may be obtained from family members present, a person who may have witnessed the situation, bystanders, medical alert jewelry, other patient medical history documentation. So medical alert jewelry, some people carry bracelets on them that have a DNR, or they have an allergy to peanuts, allergy to shellfish, anything like that, allergy to medicine, penicillin, sulfa. Use OPQRST mnemonic to assess symptoms. Onset, provocation, or palliation. What does anything make it better or worse? Quality. What does the pain feel like? Is the pain sharp? Is the pain dull? Okay. Where is the pain? Region, radiation. Can you point to where the pain is? Okay, does the pain go anywhere? Does it go up to your shoulder? Does it go down to your leg? Does it go down to your back? Severity, on a 1 to 10 scale. How bad is the pain? 10 being the worst pain you've ever felt in your life before, and 1 being the little or no pain. Timing. It's basically the same thing as onset. How long has the pain been going on for? When you come on scene, you're going to ask, when did the pain start? Did the pain start 10 minutes ago? Did it start 2 hours ago? Did it start 2 days ago? Okay. How long have you been having this pain? And then identify pertinent negatives. So, chest pain. Are you having any shortness of breath? Are you having an abdominal pain? Any nausea, vomiting, diarrhea, anything like that? Okay. Use a mnemonic sample to obtain the following information. Signs and symptoms. What is the patient telling you is wrong with them? Okay, what are you seeing is possibly wrong with them? Okay, allergies. Are they allergic to anything? Are they allergic to any medications? Are they allergic to any food? Allergies is a big one because the hospital is going to want to know that. The doctors are going to want to know that. They have to give any medications. Since EMTs don't really give medications, it's not too, excuse me. Sorry about that, class. So allergies, just make sure you ask any allergies. Yes, you're not giving many drugs out in the field, but it's always important to ask about allergies. So say if you need to give them aspirin or if you're assisting them with nitro, you want to make sure that you know what their allergies are before you give them any medications. Okay. Medications as well. You want to ask them, do they take any medications? Can I see a list? Can I see where all your medications are? Some people have their list written out. And this is a good thing to know your pharmacology, to know different medications and what they're used for, because you could kind of decipher what medical problems they have, because a lot of patients don't understand why they're taking medications. And then pertinent past medical history. What kind of medical problems do you have? Are you diabetic? Have you had a stroke before? Do you have diabetes, high blood pressure, anything like that? And then last time you ate or drank anything. So this is always important to ask too as well, because if the patient needs surgery, the doctor or the surgeon is going to want to know when's the last time they ate or drank anything. Okay, and then events leading up to the injury or illness. What was the patient doing when the symptoms started or their chief complaint started? Okay, critical thinking and assessment, gathering, seeking facts, evaluating, considering what the information means. Synthesizing, putting the information together to plan scene management and patient care. So when you're doing your patient assessment, you're trying to gather all the facts, you're trying to gather all the history, and then you're going to evaluate based on everything that you're seeing, based on the vital signs, based on what the patient's telling you, and then you're going to put everything together. All while you're doing this, you're talking to the patient, you're figuring out what's going on or what might be going on, and then you're going to decide which hospital that they need to go to. Taking history on sensitive topics, alcohol and drugs. Signs may be confusing, hidden, or disguised. Patient may deny having any problems. History gathered may be unreliable. Do not judge the patient. Be professional in your approach. So always be professional at all times. Physical abuse or violence. Report all physical abuse or domestic violence to the appropriate authorities. Follow local protocols. Do you have to go out and fill out a form? Do you have to talk to your supervisor? Do you have to fill out a form at the hospital? You want to make your suspicions known to the nurse, to the doctor. Do not accuse. Instead, immediately involve law enforcement. So you don't want to accuse anybody, but you want to say, hey, I'm seeing some bruises that might be old, but they're talking about something else, and the story doesn't add up. So can you look into that further? Sexual history. Consider all female patients of childbearing age who report lower abdominal pain to be pregnant. Inquire about urinary symptoms with male patients. When appropriate, ask all patients about the potential for sexually transmitted diseases. Special challenges in obtaining patient history. Silence. Patience is extremely important. You have to be able to let patients answer questions. Some patients aren't very forthcoming at times, and maybe you have to ask them a few more times what's going on. Use a close-ended question that requires a simple yes or no answer. Consider whether a silence is a clue to the patient's chief complaint. And like I said, you could always ask bystanders, family members, friends, anybody that knows the patient what's going on. Overly talkative. Reasons why a patient may be overly talkative. Excessive caffeine consumption, nervousness, ingestion of cocaine, crack, or methamphetamines. Underlying psychological issue. Multiple symptoms, often true of older patients. Prioritize the patient's complaints as you would in triage. Start with the most serious and end it with the least serious. So sometimes you get patients who call you and you ask them what's going on. Well, I have abdominal pain, I have a headache, I have pain all over. Okay, and then you want to keep asking questions about everything else. And then you ask them, okay, what's bothering you the most right now? Oh, I have a headache. I have a really bad headache. It's been going on for 2 weeks now. I really want to get checked out. Okay. Anxiety. Some anxious patients may show signs of psychological shock, pallor, diaphoresis, shortness of breath, numbness in the hands and feet, dizziness or lightheadedness, loss of consciousness. Anger and hostility. Friends, family, or bystanders may direct their anger and rage toward you. Remain calm, reassuring, and gentle. If the scene is not safe or secured, get it secured. So you could see if the patient can walk to the back of the ambulance, close the doors, get away from that environment. Ask friends and family members to step outside so you can talk to the patient and just make sure they're okay. Intoxication. Do not put an intoxicated patient in a position where he or she feels threatened. Potential for violence and physical confrontation is high. Alcohol dulls the patient's senses. Crying. A patient who cries may be sad, in pain, or emotionally overwhelmed. Remain calm, be patient, reassuring, and confident, and maintain a soft voice. Depression. Among the leading causes of disability worldwide. Symptoms include sadness, hopelessness, restlessness, irritability, sleeping, and eating disorders, and a decreased energy level. Be a good listener. Listen to what the patient's telling you. Confusing behavior history. Conditions such as hypoxia, stroke, diabetes, trauma, medications, and other drugs could alter a patient's explanation of events. Older patients could have dementia, delirium, or Alzheimer's disease. So you want to gather all the facts. You want to see what else may be causing the confusing history, the confusing behavior. Limited cognitive abilities. Keep your questions simple and limit the use of medical terms. So you want to ask people in layman terms, in simple terms about what's going on. Most people don't understand the medical field. It's like a foreign language to some people, so you have to keep your questions simple. Be alert for partial answers and keep asking questions. Some patients only give you half answers, half truths, and you got to keep asking questions. Maybe ask it in a different way. Rely on the presence of family, caregivers, and friends to supply answers. Cultural challenge. Do not use medical language. Patients may prefer to speak with healthcare providers of the same gender. Gain the assistance of the patient's friends or family members. Enlist the help of healthcare providers of the same culture or background if possible. So if I come on scene and I have a young lady, a teenager, a female who's shy and doesn't want to answer questions, there could be a multitude of reasons why she doesn't want to answer questions. Maybe she's pregnant and the family doesn't know and she doesn't want to answer those questions, or maybe she's just shy and rather talk to another woman on scene. So if I have a partner who's a woman, I'm going to go ahead and ask her or tell her to ask some questions for me so we kind of figure out what the problem is, because she's going to feel a little bit more comfortable talking to a woman. The language barriers. Find an interpreter if possible. So if you get on scene and a family member, say, speaks English or Chinese or whatever the case may be, you're going to see if maybe a possible young child is there that helps translate for you. So if not, determine if the patient understands who you are. Keep questions straightforward and brief. Use hand gestures. Be aware of the language diversity in your community. Hearing problems. Ask questions slowly and clearly. Use a stethoscope to function as a hearing aid. Learn simple sign language to help with communication. Use a pencil and paper. Sometimes this is the best bet. You have to ask them questions and they're hard of hearing and you don't want to yell on scene. So you're going to write down questions. You're going to ask them, what's going on? Any questions about your chief complaint? So visual impairments. Identify yourself verbally when you enter the scene. Return any items that have been moved to their previous positions. So if you bring a gurney in, or you bring a stair chair in, or you bring a flat in, and you can't get around some furniture, so you move the coffee table off to the side, or you move the recliner, or the couch, or the kitchen table out of the way. It's important to also be respectful of their possessions. You want to make sure to put them back where you moved them, where in their original position. Explain to the patient what is happening in each step of the vital signs assessment. So you always want to tell the patient what you're doing, what's going on, so they're informed, so they understand what's going on. Secondary assessment may be performed on scene, in the back of the ambulance, en route to the hospital, or not at all. Purpose is to perform a systemic physical examination of the patient. Maybe systemic head-to-toe secondary assessment, or an assessment that focuses on a certain area or system of the body. So if a patient's just telling you chest pain or just abdominal pain or back pain and nothing else, you might focus just on that certain area. If they're kind of giving you a general or a broad chief complaint, you're probably going to do a head-to-toe secondary assessment to kind of help you with clues about what's going on. How and what to assess. Inspection. Look at the patient for abnormalities. So you look at their skin color. Are they pale, cool, diaphoretic? Do they look cyanotic? Do they look short of breath? Are they breathing rapidly? Are they hunched over? They're grabbing their abdomen because they're having abdominal pain. So palpation. Touch or feel the patient for abnormalities. Does the patient have a bump on his arm from falling out of his chair, out of his bed? Does he have a bump on his head? Does he have a laceration to the back of his head? Auscultation. Listen to the sounds a body makes by using a stethoscope. So listen to lung sounds. If he's complaining of shortness of breath or difficulty breathing, they're going to listen to lung sounds, upper, lower, and sides, front and back as well. So use the mnemonic, DCAP, BTLS. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. So when you're doing a secondary assessment, you're doing that on all body parts. You're using DCAP, BTLS. Compare findings on one side of the body with the other side when possible. So I showed you a femur fracture when we were doing traction splints the other day, and we showed that video. One guy's, his right thigh was bigger than his left, and it was shortened and rotated. So you always want to look on the other side of the body. Does it look normal? Does it look like the same as the other side of the body? And that will kind of give you clues. Like, hey, that doesn't look right. So I'm going to go ahead and do an assessment. I'm going to see, do I feel any crepitus, broken bones? Does it feel normal to the other side? Systemically assess the patient, secondary assessment. The goal is to identify hidden injuries or identify causes missed during 60 to 90 second exam during primary assessment. So this is exactly why you always do a secondary assessment and a reassessment, because you'll have distracting injuries. Patient's got a broken bone that's 90 degrees the other way. You want to make sure that he doesn't have a huge laceration in the middle of his back and he's bleeding out. This is important to always do a secondary assessment and a reassessment to find out things that you may have missed, because patient may not feel the laceration on his back because his leg's broken so bad and he's in so much pain. Focus assessment performed on patients who have sustained non-significant MOIs or mechanism of injury, or on responsive medical patients, typically based on the chief complaint. So what is the patient telling you? He has chest pain, shortness of breath. Goal is to focus your attention on the body part or systems affected by the priority problems. Respiratory system. Expose the patient's chest. Look for signs of airway obstruction. Inspect for symmetry. So, does it look like he has got equal chest rise and fall? Listen to breath sounds. When you're doing your ABCs, airway, breathing, circulation, make sure he has an airway. Looking at breath signs, how's he breathing? Okay. Go ahead and listen to all lung sounds. Measure the respiratory rate. Is it within normal limits? Is he breathing shallow? Is he breathing rapid? Look for retractions and increased work of breathing. Respiratory rate. A normal rate in adults ranges from 12 to 20 breaths a minute. Children breathe at even faster rates. Count the number of breaths in a 30-second period and multiply it by 2. So if the patient's breathing 10 times in 30 seconds, you're going to multiply that by 2. So he's breathing 20 times a minute. Respiratory rhythm. Regular. The time from one peak chest rise to the next is fairly consistent. Irregular. The respirations vary or the rate changes frequently. Quality of breathing. Normal breathing is silent. Breathing accompanied by other sounds may indicate a significant respiratory problem. So something you may have to fix. So try and listen carefully. If it sounds like the patient's having labored breathing, is the patient wheezing? Depth of breathing. Amount of air the patient exchanges depends on the rate and tidal volume. Breath sounds. You can almost always hear breath sounds better from the patient's back. Okay. So these are where you're going to listen to breath sounds. You're going to go upper and lower, and same thing, upper and lower, and then also on the sides. So right down here, and then on the other side, right over here. Yeah. What are you listening for? Normal breath sounds, snoring breath sounds, wheezing breath sounds. So wheezing, you're probably going to have a breathing treatment. They probably have history of either COPD or asthma. Crackles. Does he have fluid at the bases of his lungs? Does he have CHF? Rhonchi. Does the patient have a cold? Does he have pneumonia? Basically, mucus in the system. Mucus in the lungs, excuse me. Stridor. That's an upper airway problem. Cardiovascular system. Looking for trauma to the chest and listen for breath sounds. Consider the pulse, respiratory rate, and blood pressure. Pay attention to rate, quality, and rhythm. So is patient's pulse fast? Is he breathing fast? Look at his blood pressure. If his blood pressure is a little low and his pulse is high and his respiratory rate's high, his body's compensating right now. He's possibly going to go into shock. Consider your findings when assessing the skin. check and compare distal pulses. Consider auscultation for abnormal heart sounds. So you're always checking when you're doing a trauma assessment. You're checking pulses in all extremities to make sure that they're getting enough blood flow. So pulse rate. Normal resting pulse for an adult is between 60 to 100 beats a minute. The younger the patient, the faster the pulse. And so preschooler 2 years, 10 years, a little faster, 60 to 140. Infants and toddlers, 3 months to 2 years, it's going to be 100 to 190. Infants up to 3 months of age, 85 to 205. Pulse quality. Describe a stronger than normal pulse as bounding. A pulse that is weak and difficult to feel is described as weak or thready. This may indicate a serious condition. This may indicate blood loss. Pulse rhythm. Regular. The interval between each contraction should be the same. The pulse should occur at a constant, regular rhythm. So do you feel a pulse at every 2 seconds? Do you feel a pulse every 5 seconds? Is it consistent? Irregular. The heart periodically has an early or late beat. If a pulse beat is missed. Blood pressure. Pressure of circulating blood against the walls of the arteries. A drop in blood pressure may indicate a loss of blood or fluid components, a loss of vascular tone and sufficient arterial constriction, a cardiac pumping problem. Decreased blood pressure is a late sign of shock. Abnormally high blood pressure may result in a rupture or critical damage in the arterial system. A blood pressure cuff with a gauge contains the following components: a wide outer cuff, an inflatable wide bladder, a ball pump with a one-way valve, and a pressure gauge. So auscultation is the most common means of measuring blood pressure. So auscultation means listening. So you're going to have the stethoscope actually where this patient's hand or fingers are. Palpation method does not depend on the ability to hear sounds. So if you're going to palpate a blood pressure, you're going to find the radial pulse right down here with your 2 fingers, and you're going to pump up to 160 or 200, whatever you normally pump up to. Release the air, and then the first pulse you feel is going to be your palpated blood pressure. And so how you're going to write that down is, say if you get the first beat you feel, say it's at 140, it's going to be 140 over palp or 140 over P, because you're not going to be able to get a diastolic if you don't auscultate. So that's how you palpate a blood pressure. Normal blood pressure. Hypotension. Blood pressure is lower than normal. Hypertension. Blood pressure is higher than normal. So remember, systolic is going to be the first number, and diastolic is going to be the second one. So these are your normal ranges for blood pressure for adults all the way down to neonates. So remember, neonates, the smaller the kid, the lower the blood pressure is going to be, but the higher the respiratory rate and the higher the heart rate. Neurologic assessment should be performed with any patient who has changes in mental status, possible head injury, stupor, dizziness, drowsiness, or syncope. Evaluate the level of consciousness and orientation. Use the AVPU scale if appropriate. The Glasgow Coma scale can be helpful in providing additional information. So this measures eye verbal motor, and you're going to get different numbers for each one, and they're going to add up to 15. So 15 is a really good, the best GCS score you're going to get. 3 is going to be the lowest. Pupils. The pupil is the black center portion of the eye. The pupils are normally round and of approximately equal size. In the absence of any light, the pupils will become fully relaxed and dilated. So constricted, dilated, unequal. Okay. So constricted, it's probably going to be under the influence of some type of drug, some type of narcotics. So if you believe someone's under the influence of some type of narcotics like heroin, You're going to check their pupils and see. And that's probably going to give you a good indication. If you think they might be under some amphetamines, their pupils are probably going to be dilated. And so this is unequal right here. This could be a sign of a head injury, a stroke, an aneurysm. So always checking the pupils. They say pupils are the eyes to a window's soul. A small number of the population exhibit unequal pupils. So if a patient has unequal pupils, be very aware of a possible head injury. Causes to depressed brain function, injury of the brain or brainstem, trauma or stroke, brain tumor, inadequate oxygenation or perfusion, drugs or toxins. Pearl is a useful assessment guide. Pupils equal and round, regular in size, and react to light. Neurovascular status. Check for bilateral muscle strength and weakness. Complete a thorough sensory assessment. Test for pain, sensations, and position. Compare distal and proximal sensory and motor responses in one side with the other. Anatomic regions. Head, neck, and cervical spine. Palpate the scalp and skull. Check the patient's eyes. Make sure they're pearl. Pupils equal, round, and reactive to light. Check the color of the sclera. Assess the patient's cheekbones. Check the patient's ears and nose for fluid. This could be possible basilar skull fracture, or they could have some type of bleeding in there. Okay. Head, neck, and cervical spine. Check the upper maxilla and lower mandible, jaw. Open the patient's mouth and look for any broken or missing teeth. Note any unusual odors in the mouth. So when you're opening the patient's mouth, you want to make sure there's no broken or missing teeth, because if they have some broken or missing teeth, they could swallow it, and that could cause an airway problem. If a patient has a seizure, you want to open up their mouth and see if they bit their tongue. Does the patient smell like alcohol? Does the patient have kind of a fruity tone to their mouth? Because that could be considered a hyperglycemic patient. Chest. Inspect, visualize, and palpate. Watch for both sides of the chest to rise and fall together with normal breathing. Observe for abnormal breathing signs. Abdomen. Palpate for tenderness, rigidity, and patient guarding. 4 quadrants. Left upper, left lower, right upper, and right lower. Pelvis. Inspect for symmetry and any obvious signs of injury, bleeding, and deformity. So you're always checking both sides. Remember, you want to see if one side looks abnormal, one side feels tender and not the other. Extremities. Inspect for symmetry, cuts, bruises, swelling, obvious injuries, and bleeding. Palpate for deformities. Check for pulses and motor and sensory function. So you're checking for CSM in all 4 extremities. When you're done palpating and inspecting each extremity, you're going to go ahead and finish off and check CSM. Posterior body. Inspect the back for decap BTLS, symmetry, and open wounds. Palpate the spine from the neck to the pelvis for tenderness and deformity. Use appropriate monitoring devices. Should never replace your comprehensive assessment of the patient. So you're going to treat the patient. Don't treat the monitor. Sometimes the monitor gets thrown off. Look at the patient. How are they presenting? Do they look like they're in distress? Do they look like they're having a hard time breathing? Treat your patient, not the monitor. Pulse oximetry. Used to evaluate oxygenation's effectiveness. So you guys can get these. Pulse oximetry. You can buy them on Amazon for $20. So it's going to tell you right here. It's going to tell you SpO2. It's going to tell you how much oxygen you're getting. So he's getting 93% right now. And then it's going to tell you your pulse rate. It's going to be 73 right now. And then this is going to be your oxygen waves, basically, for your SpO2 and what it's reading. A lot of people with COPD or CHF have this who are on oxygen because they want to check their oxygen levels. Pulse oximetry measures the oxygen saturation of hemoglobin in the capillary beds. Patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. So, no matter what, you have to give patients oxygen if they're having difficulty breathing. It's important because just because they have a good pulse oximetry value doesn't mean they're not having difficulty breathing or they don't need oxygen. It just measures, the pulse oximetry measures the saturation of hemoglobin in the capillary beds. It doesn't measure what is saturating the hemoglobin. So if carbon dioxide combines with your hemoglobin about 264 times more than oxygen. So if you're bringing somebody out of a fire that was inside, say a male adult was in there and a fire broke out and he was in there for 10 minutes and you put him on pulse oximetry and he's 100%, you're going to put that patient on oxygen because the carbon monoxide from the fire is probably the one reading off the pulse oximetry. It saturates your hemoglobin more than oxygen does. So anytime you have a patient who comes out of a fire, you're going to throw them on oxygen no matter what, because a pulse oximetry could be bad. Capnography can quickly provide information on patients' ventilation, circulation, and metabolism. Blood glucometry measures the level of glucose in the bloodstream. So diabetics, you always want to get their blood sugar. You want to know if it's low, high, or within normal limits. For our county protocol, anything below 70, you're going to be considered hypoglycemic, and I have to give them sugar for it. If they have their own monitor at home, you could ask them, hey, can we check your blood sugar real quick? We just want to make sure it's okay. Because as EMTs, you don't give dextrose, you don't give them sugar. You can't. That's outside your scope of practice. So if their blood sugar is reading low and they want to go to the hospital, you're going to ask their family members, hey, can we make you a sandwich real quick? Because I want to get that sugar up. So non-invasive blood pressure measurement. The sphygmomanometer blood pressure cuff is used to measure blood pressure. So reassessment, perform at regular intervals during the assessment process. Repeat the primary assessment. Reassess vital signs. Compare with the baseline vital signs obtained during the primary assessment. Look for trends. So you're performing at regular intervals. So trauma patients or unstable patients, you're providing at every 5 minutes. For stable patients, you're doing every 15 minutes. Repeat your primary assessment. Make sure they still have an airway. Make sure they're still breathing okay. Make sure their circulation's still good. They're still perfusing. And you're going to reassess your vital signs. You're going to check your blood pressure. Is it high? Is it low? Is it within the normal one? The first blood pressure you have, is the heart rate still within a few beats of the normal one? Look for trends. So if you have a trauma patient and the initial blood pressure was 140 over 90, the next one you get is 110 over 70, and then it keeps going down, he's probably losing blood. He's losing fluid. So that's going to be a good trend. Probably a bad trend. And you want to let the hospital know. Okay. Reassess the chief complaint. Ask and answer the following question. Is the current treatment improving the patient's condition? Is the patient having chest pain? Did you give him aspirin? Did the aspirin help? No? Okay. Can we do nitroglycerin? Is that going to improve? Has an already identified problem gotten bigger? So is a patient telling you that he's got a broken leg and it looks like he's having more pain than before? Okay. Has an already identified problem gotten worse? What is the nature of any newly identified problems? Recheck interventions. Check all interventions. Most important are the patient's ABCs. Ensure management of bleeding. Ensure adequacy of other interventions, and consider the need for new interventions. So if you splint a patient, make sure all the straps are still tight, are still holding the patient's extremity in place. Make sure the patient still has a good airway, his breathing's good, his circulation's good. Ensure management of bleeding. So if you have an arterial bleed and you put a tourniquet on, you have to make sure that the bleeding is still stopped, because sometimes patients still bleed. Maybe the tourniquet came loose while you're moving the patient to the gurney, and now the patient's bleeding again. So you want to make sure that everything you do is still helping out the patient. And then, do you see anything else? This is why we do reassessment. You want to consider the need for new interventions. Do we need to throw another tourniquet on that patient who's bleeding? Does it look like the patient has 2 femur fractures now? So now we're going to go ahead and splint the other leg, put them in a traction splint. Identify and treat changes in the patient's condition. Document any changes, whether positive or negative. So any pertinent positive or any pertinent negative changes. So if you give a patient aspirin and he's complaining at 8 out of 10 chest pain before, and now he's complaining at 6 out of 10, that's a positive change in the patient's condition, because you treated him and he got better with aspirin. So reassess the patient. So after every time you do an intervention, you want to check a blood pressure. So you gave him aspirin, so I'm going to go ahead and take another blood pressure, and then I could consider nitro. Okay. Reassess the patient. Unstable patients approximately every 5 minutes. Stable patients approximately every 15 minutes. So if you have a stable patient and you're 10 minutes away from the hospital, you're going to get 2 blood pressures. Always 2 sets of vital signs, no matter what. A review. During the scene size up, you should routinely determine all the following except okay, so go through your list. Go through Penman. Do you have your PPE? Is the scene safe? How many patients do you have? What's the mechanism of injury? Do you need additional resources? Do you need for C-spine? Is it a traumatic event? Yeah, so B, components of the scene size up. After taking standard precautions, include determining if the scene is safe, determining the mechanism of injury or nature of illness, determining the number of patients, and determine if resources are needed at the scene. So you arrive at the scene of an injured person. As you exit the ambulance, you see a man lying on the front porch of his house. He appears to have been shot in the head and is lying in a pool of blood. You should okay. So is the scene safe? Who else is with you? D, your primary responsibility as an EMT is to protect yourself. Prior to entering any scene, you must assess for potential dangers. In cases where violence has occurred, you must retreat to a safe place and wait for law enforcement personnel to arrive. So if you see something that could potentially be a hazard to you, you have to make sure the scene's safe. You could ask for PD. Sometimes you're going to get calls for medicals, unknown medicals. We get them all the time. We don't know what we're walking into. People call and they won't tell a dispatch what's going on. So always have that in the back of your mind that something could go wrong. We don't know what we're stepping into because people don't want police to be called. Always protect yourself. Findings such as inadequate breathing or an altered level of consciousness should be identified in what part of the assessment when you're coming on scene is going to be you're going to be looking for inadequate breathing. When you first walk in, you're looking at a patient. Even before you talk to them, you're sizing the patient up. You're determining what his chief complaint is. Where is he situated? Is he breathing? Is he conscious? Is he tracking you? Does he have an airway? Okay. A, the purpose of the primary assessment is to identify and manage any life threats to the patient, such as inadequate breathing, an altered level of consciousness, or severe hemorrhage. Which of the following would you not detect while determining your initial general impression of the patient? So D, initial general impression is what you first notice as you approach the patient, but before physical contact is what the patient is made. It is what you see, hear, or smell. A rapid heart rate would not be detected until you actually perform the entire primary assessment. You cannot see, hear, or smell tachycardia. So when you're walking up, you could see if a patient's cyanotic. Do they look blue? Do they gurgling respirations? Can you hear that when you're walking in? Severe bleeding. You can see if a patient's bleeding or not, if they're having severe bleeding. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine and administering oxygen, you should Okay, so you're going to go in order of your assessment. Make sure you know your assessment. Make sure you know your steps, your Penman, your general impression, your ABCs. What are you going to do next after a trauma patient? Or is it a medical? So B, if any life-threatening problems are discovered in the primary assessment, they should be addressed immediately. The EMT should then perform a rapid exam to look for other potentially life-threatening injuries or conditions. So this one, they kind of jump ahead a little bit. So you've already administered oxygen. So you have her ABCs, you have her airway and breathing. And so you're going to go on the primary assessment, primary assessment. So you're going to perform a rapid exam because it's a trauma. Most likely, for a trauma, you're going to do your physical first because that's going to tell you what's going on. For trauma, you want to do a rapid exam to see if there's any other issues going on with the patient. Medical history is still important for every call, but most likely the issue going on with her is more of a trauma. So you want to figure out what else is going on. What else do you see? A semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as... So semi-conscious, would you say that's alert? Would you say it's unresponsive? Would you say he moved away after either painful or verbal stimuli? What did you do for the patient right now that caused him to push your hand away? Semi-conscious patients are not alert, nor are they unresponsive. The fact that the patient pushes your hand away when you pinch his earlobe indicates that he is responsive to painful stimuli. If he opens his eyes or responds when you speak to him, he would be described as being responsive to verbal stimuli. Assessment of unconscious patients' breathing begins by... What's the first thing you're going to do? B, you cannot assess or treat the unconscious patient's breathing until the airway is patent, that is, open and free of obstructions. Manually open the patient's airway, e.g. head tilt, chin lift, jaw thrust. Use suction as needed to clear the airway of blood or other liquids. Insert an airway adjunct to assist in maintaining airway patency, and then assess the patient's respiratory effort. So you want to position the head first. That way you open it up, you see what else is going on. Then, if the patient has blood, vomit, secretions, anything like that, you go ahead and suction as needed. Then you could go ahead and insert an airway. And then you could go ahead and assess respiratory rate and depth. So make sure you guys are always going in order of everything. Your 12-year-old patient can speak only 2 or 3 words without pausing to take a breath. He has a serious breathing problem known as we talked about this earlier. Remember when I was asking about the patient with the respiratory difficulty? And he can only speak in 2 or 3 word sentences. So he's having B, 2 or 3 word dyspnea, is a severe breathing problem in which a patient can speak only 2 to 3 words at a time without pausing to take a breath. Yeah, he's having labored breathing as well. But look at what the question is telling you. 2 or 3 words and 2 or 3 word dyspnea. So, definition is basically right in here. 2 or 3 words without pausing to take a breath. How should you determine the pulse in an unresponsive 8-year-old patient? So, is a patient considered an adult, or is a patient considered a pediatric still? And where would you palpate for an adult? Where would you palpate for a pediatric? D. An unresponsive patient older than 1 year, you should palpate the carotid pulse in the neck. If you cannot palpate a pulse in an unresponsive patient, begin CPR. So, patient's not a pediatric anymore. He's 8 years old, right? So anybody older than 8 years old, you're going to do a carotid pulse in the neck. When assessing your patient's pain, he says it started in his chest but has spread to his legs. This is an example of what part of the OPQRST mnemonic. So go through the whole mnemonic in your head. Onset. When did the pain start? P. Provocation, palliation. Anything make it better, anything make it worse. Quality. What does the pain feel like? Is it dull? Is it crushing? Is it sharp? Radiation, region. Where is the pain located? Can you show me? Can you point with the finger? Okay, does the pain go anywhere? Does it go up your shoulder? Does it go down your side? Does it go down your back? Severity, 1 out of 10, pain. 10 being the worst pain you've ever felt in your life before. 1 being either little or no pain. And then time. How long has it been going on for? So what is the question asking you? When assessing your patient's pain, he says it started in his chest but has spread to his legs. So that spread is another word for what? Radiation. Where did the pain radiate to? Where did the pain spread to? So the region radiation section of the OPQRST mnemonic assesses a patient's pain, where it hurts and where the pain has spread. Because the patient informed you that his pain has spread from his chest to his legs, this would be an example of radiation. So onset. Assess the cause of the pain and when it began. What were you doing when the pain started? Quality. The description of the pain. Can you describe it for me? Severity. How bad is the pain on a 1 to 10 scale?